Welcome to the Pacific Research Institute's Next Round podcast. I'm Rowena Itchon, Senior Vice President, and with me is Tim Anaya, Senior Director of Communications.
Hi, Ro.
Hi, Tim. So the subject of this podcast is healthcare, which is very popular among all of our listeners. We always get a great audience size when we do podcasts on healthcare. So few state governments have a greater presence in healthcare, in the healthcare market, than California's does. All that government involvement has contributed to spiraling costs for people who have to rely on the state for coverage. So first, in California, we got the individual insurance mandate, which took effect last year in 2020. So California requires that all state residents to get health care insurance, if they don't have health care insurance, pay a fine of $750 or 2.5% of their household income. And the state projects that this mandate brings in about $1 billion over the next 3 years. Then we've got Covered California, which is the name of California's Obamacare program here. The annual premium, Sally has said, is about $5,100 now in 2021. And that doesn't even include the annual deductibles, which can be thousands more. So a person has to spend, upwards of $10,000 before he even gets a dollar from their insurance. And finally, we've got Medi-Cal, which is expanded in a big way in the last several years. So we've now have 13 million Californians on Medi-Cal, and that's about a third of the population, if you can imagine that. And it's costing the state about $120 billion, about 3 times more than what cost us a decade ago. And to top it all off, Tim knows about this, is that Newsom in 2019 signed a budget to include undocumented immigrants between the ages of 19 and 25. So now we've got about 200,000 undocumented immigrants, children and young adults, that we're paying Medi-Cal for. And just recently, this is in 2020, Newsom wants to add older undocumented immigrants, which would cost another $2.6 billion. Older people get sick more often, so it's going to be a pretty big bill.
I think in the budget is going to be enacted, hopefully later today as we tape this on Monday, it's supposed to be, I believe it was undocumented immigrants over age 50 are going to be included. So very expensive indeed.
So, Tim, what's happening with AB 1400? It got shelved, didn't it?
It did for the year. And of course, it always comes down to the main issue that Speaker Rendon has said many times before. Well, how are we going to pay for this? When past iterations of this have come down to being estimated as being double the annual state budget. Well, there's no real feasible way to pay for this. The interesting thing now is that with Governor Newsom facing the recall election this late summer or early fall, whenever it will be, you're seeing that his allies in the California Nurses Association and those who are the real advocates of single payer, well, now they're starting to ramp up some pressure on Governor Newsom and are trying to say, hey, we're all out here defending you. When are you going to step up to the plate and push for single payer? So remember, Gavin Newsom is a big proponent of single payer, but he realizes the political peril of this and, how difficult it's going to be. So he created this single payer commission, which our Sally Pipes laments she was not appointed to. And the people on the commission are basically people who would be inclined to support single payer. And that they're charged with figuring out a way that you could devise a single payer system in California and pay for it. That commission still has not issued its final report. That's kind of a good way of sticking it in on the shelf for a while, getting people off of his back. Well, with the unions rallying at the Capitol last week and demanding that Governor Newsom take action on single payer, it's going to be interesting to see what, are we going to have a more realistic push towards single payer? The Newsom administration did write a letter to fellow Californian Javier Becerra, who's now the Secretary of Health and Human Services. They basically have requested that California be given a waiver to do, a single payer type system in California. So will Becerra, who is a single payer supporter, will he go along with that, even though President Joe Biden is an opponent of single payer and he just wants a public option? So it's interesting to see what course will be charted, but it seems like even though 1400 has been shelved, we could see some real action on single payer in 2022.
And Tim, whatever happened to that proposal, or actually it passed, on California having its own drug label?
Sure. So the bill was Senate Bill 852, and it was signed into law last fall. And it really is more kind of the starting point for a state prescription drug label. So the bill basically directs the Health and Human Services Agency in California to explore partnerships with drug makers to, quote, make drugs more affordable and accessible in California. So it wouldn't have the state actually be in the business of developing new drugs, but it would try to make what they say are cheaper versions of generic drugs or drugs that aren't covered by patents. Well, as our Wayne Weingarten has said in his work, generics aren't the issue. Most people take generics. They're, significantly less expensive. The issue is our crazy drug pricing system. And how do we cover those new, innovative, expensive, life-saving medications and treatments? And Wayne has suggested a whole bunch of reforms. I invite you all to check out our Escape the Drug Pricing Maze animated series that I'm particularly proud of. And, you can learn for yourself about how our drugs pricing system is broken and reforms that would ensure patients continue to have access to these cutting edge treatments at a more affordable price.
Thanks, Tim. So this next podcast is actually a live event, a panel discussion on healthcare in Phoenix, Arizona, sponsored by our colleagues at the Goldwater Institute. So from the Goldwater Institute is Director of Healthcare Policy, Naomi Lopez, and she leads Goldwater's efforts in implementing federal and state healthcare reforms. And also on our panel, of course, is our fearless leader who needs no introduction, Sally Pipes, President and CEO of PRI, and the Thomas W. Smith Fellow in Healthcare Studies. So we hope you enjoy the podcast event. Thanks for listening, everyone. And here's Naomi Lopez and Sally Pipes.
Well, welcome, everyone. My name is Austin Jack. I'm the Chief Development Officer here at the Goldwater Institute. It is so great to see everybody in person, shaking hands, and without masks on. So thank you all for joining us here today. That's right. But we hope you're just as excited to see us. We've got an excellent program prepared for you today about unleashing healthcare freedom throughout the United States. Our wonderful lineup of speakers, Sally Pipes from Pacific Research Institute, who are our dedicated partners in today's event, Naomi Lopez, who's our Director of Healthcare Policy at this institute, and also I'd like to now invite up our President and CEO and fearless leader, Victor Riches, to share a few words with you, and we'll go ahead and get started. So thank you so much.
Well, thank you, Austin. And I do want to start by thanking Sally and the Pacific Research Institute for sponsoring this event with us. And I cannot reiterate enough what Austin said. It's been too long since we got to get together in person. It's been too long since we got to see a lot of you. So thank you all very much for coming out here today. And I really think that we could not be talking about a more important subject than healthcare freedom. And we've all seen over the past, well, now it's been about 18 months. We've seen the left politicize COVID and use it to justify not only shutting down the economy, but frankly as a catalyst for almost every crazy idea they can dream up. And that includes the idea of eliminating private health insurance. And when you think about what that would mean we would literally kick 220 million Americans off of their insurance with very little regard to what that does to healthcare in this country, let alone the economy. And one point I want to make on the economy, believe it or not, the feds have now spent $6 trillion on what they call COVID relief. And just to put that in perspective, that is 27% of our country's GDP. But when you actually look at the legislation, when you look at that last bill they just passed about a month ago, only 8% of those dollars actually went to COVID mitigation. And even if you add in all of the stimulus checks, and I don't know about you guys, I think these stimulus checks are one of the biggest scams the government has ever perpetrated, literally paying people not to go to work. But even when you add in those stimulus checks, it still only accounts for a very small percentage of their funding. But I do think that really illustrates how the government looks at healthcare. They first used COVID to shut down the government, purposely make people lose their jobs, but then they come in at the 11th hour, swoop in with these COVID stimulus checks, and basically repair the damage that they themselves caused. But I do want to stress, and if there's one thing I'd really like to leave with everyone here, is I do think there's a great silver lining in all of this. And I suspect, like a lot of you, I meet with a lot of people, and I really don't think that most people are buying this nonsense. I think people see the government wasting money. I think they see the government overreaching when it comes to healthcare decisions. And I think people are starting to recognize that there are actually free market solutions. And with groups like the Goldwater Institute and the Pacific Research Institute, I really think that the sky is the limit for what we can accomplish moving forward. And I'll just give you one quick example, and I'm sure Naomi's going to touch on this a little bit more in a few minutes. But just a handful of days ago, we passed right out here in Arizona the first universal telemedicine bill anywhere in the country. And I can promise you, oh, thank you. And I can promise you, we're going to take that bill and we're going to move it across the rest of the country and pass it in every other state and really demonstrate what you can do when you take the government and you remove it from the equation. When you do that, great ideas have the opportunity to flourish. And today, we're very fortunate, as Austin mentioned, to have two of the truly leading voices in the fight for healthcare freedom. We have our very own Naomi Lopez. She's the Director of Health Policy at the Goldwater Institute, and it would not be an exaggeration to say she is the key to all of our work at the Institute. So whether it's the universal telemedicine, whether it's FDA reforms, whether it's expanding right to try, Naomi is the key to all of that work, and I really believe that the work that she does lays down the blueprint for the rest of the country to follow. And I'm also extremely excited that we get to hear from Sally Pipes. Sally is the president of the Pacific Research Institute. She's long been one of my very favorite thinkers and writers, and she's been at the forefront in the fight against social medicine for a number of years. And I'd also be remiss if I didn't mention, I think everyone has a copy of her book, False Premise, False Promise. And I can tell you this, there is no greater indictment on this idea of government-mandated mandatory Medicare for all than this book. So we're very happy to have Sally here. And with that, I once again want to thank you all for being here. It really is great to see everyone. And I'm going to turn it over to our good friend, Naomi.
Thank you so much for that warm introduction. And thank you so much to you guys for showing up today and really coming together to talk about this really important issue of healthcare innovation and those issues surrounding it, such as healthcare freedom. I'm so passionate about the work that I have the opportunity to do at the Goldwater Institute and the phenomenal colleagues that work that we collaborate on all of these issues. And I thank you for your support of our work. So the COVID-19 pandemic has really opened Americans' eyes to the new challenges and opportunities in our healthcare system, like nothing else could have possibly done. Long pending reforms, such as easing restrictions on telemedicine, became a reality under the temporary lifting of restrictions almost overnight. And while we still have a lot of shortcomings in our nation's drug approval process, they were never more evident than during COVID. We still don't have a fully FDA-approved vaccine or fully FDA-approved treatment. But the fact that we were able to dose patients here in the United States less than 1 year after the first confirmed case really speaks to the potential of removing the restrictions, bureaucracy, and red tape that limit and slow down the availability of getting treatments to patients. So through it all, the Goldwater Institute provided leadership in a number of areas in healthcare reform, and we will continue to work and continue to build on the groundwork that was laid before COVID and during. And today we're offering really some truly transformational blueprints for both the reform at the federal level, primarily through the Food and Drug Administration process, but also at the state level through a number of supply-side reforms that really can unleash innovation and, more importantly, can be very patient-focused, very patient-centric, getting patients the care that they need, when they need it, in a manner that's most appropriate for them. But we still have a lot of work remaining to really achieve these principles, and that's what I'm here to talk to you briefly about today. So right now, American families cannot wait on Washington to cure the ills of the healthcare system. We know that the average family is spending upwards of $25,000 per year through their employer on insurance, and that doesn't even include the first about $7,000 in their deductible or copays. And so what we really do have is a system that spends enormous resources without getting patients value for their dollar. But fortunately, that's changing, and that's where we're working very hard to change that so that individuals can use their dollars, their hard-earned money, to get value for healthcare services that they receive and not just send money to insurers. So the first area is called scope of practice, and that's the idea that healthcare practitioners should be allowed to practice at the top of their education and training. We know that during COVID-19, most states temporarily lifted those restrictions so that, for example, nurse practitioners could do more in the hospital settings, and respiratory technicians could also do more in the hospitals. So we really did see the proof of concept that people who were able to practice at the top of their education and training weren't harming patients, they were actually helping them, and they were meeting a lot of unmet needs that would have otherwise those patients would not have been as well cared for. The next area is certificate of need laws. These are laws where a would-be hospital, surgery center, has to go to the state for permission to set up shop in that state. Let's think about if Whole Foods had to ask Kroger if they could open up a store in Scottsdale. It's absolutely absurd. No other business operates that way, but that's exactly how hospital beds are determined in most states. So we're working very hard on that issue too, and once again during COVID, those artificial restrictions were lifted, and of course, it was very helpful in terms of having enough beds for the patients that were coming in. Hospitals were able to scale up and scale down as needed, and so this is another important area of reform. The next area of reform is charity care. States can enact Good Samaritan laws that provide legal protections to those who are offering healthcare services. We saw every state actually enhance the types of protections for people that were providing charity care in the time of COVID. And then next we have direct primary care. It's called DPC for short, and it's an innovative healthcare arrangement that allows patients or their employers to contract with a provider for primary care services directly. I actually participate myself in direct primary care. I spend $75 a month for myself and then $25 for each of my 2 children, and we have pretty much 24/7 access to our provider. It's not uncommon that someone might complain of an ear infection or their throat hurting on a Sunday afternoon. I will call our DPC provider. He will meet us at his office. We'll go and meet with him. He'll run a quick test. We'll stop off at Walgreens to pick up provisions, and I will be back home within 1 hour. Since I've been participating in direct primary care, I have not hit my deductible, and I have not had to sit in an urgent care waiting room for 3 hours with people coughing all around me. So that is an example of something that provides enormous value for a healthcare dollar. The next area is telemedicine, and this is the one that I am most excited about because of the reform that Arizona just passed. It is absolutely going to transform healthcare delivery, not only for individual patients, but also in hospital settings and in the next few years in nursing home settings. In many states, it's legal for doctors to prescribe, there are a lot of restrictions where for a provider cannot provide care unless they've had face-to-face contact with that patient already. There are a lot of restrictions and limitations on prescriptions that can be provided. And in some states, they even have requirements where you cannot have a telemedicine visit unless you're actually sitting in a hospital which makes absolutely no sense whatsoever. Fortunately, Arizona's telemedicine law that just got signed by Governor Ducey not only expands and builds upon the temporary restrictions that were lifted during COVID-19, it actually goes quite a few steps further. If you recall, about 3 years ago, the Goldwater Institute was instrumental in the occupational licensing reform, which has now been exported to dozens of states around the country. But that's the idea that just because you move into the state of Arizona, you don't lose your skills and education for the job that you were certified to do in the state that you just moved from. The telehealth bill is similar in that if a patient is getting a service from an out-of-state provider, that provider only needs to register and does not need to go through the full registration process in order to provide those services. They need to be in good standing, of course, and there are some requirements on those providers. But the idea is that if I have a medical need that can be met through telehealth in a reasonable way, of course, you cannot extract a tooth via telehealth, of course. It's got to be reasonable and safe for the patient. But if it's something that can be done via telehealth, it's legal. That's the end. It's legal. So one example is a woman in Yuma, Arizona. She has a disabled daughter, and she would drive 3 hours each way from Yuma to Phoenix Children's in order for her daughter to get the care that she needed. She did this twice a week. That was 2 full days of driving through the desert with a disabled child. 2 days a week. When the telehealth restrictions were temporarily lifted during COVID, she was able to do all but one a month via telehealth. What does that mean for that family? It means an enormous amount of time. It means a more pleasant experience throughout the week. And it also means that her daughter is able to pretty much get care anytime she needs, not just on those 2 days a week. If something else comes up and she needs additional care, there's not a big obstacle of driving across the Arizona desert in order to get it. These are the kinds of reforms that we are working on. We work to get the right treatment to the right patient at the right time. We are now this week celebrating the 3rd anniversary of the federal right to try law. And while it may not get enormous fanfare, we know that program is actually extending lives. The right to try law is about recognizing and protecting the fundamental principle of patient autonomy, that the law explicitly intends to expand the scope of individual liberty and agency among patients in limited circumstances. It does this by recognizing that the deeply personal decisions belong in the hands of patients and their physicians. We're working on this goal at the federal level and at the state level, and I can tell you that I am extraordinarily optimistic about the potential to really transform the way healthcare is delivered, the quality of care that patients receive, and the restoration of the doctor-patient relationship. It is starting in Arizona and being exported across the country, but really Arizona is the model that the rest of the nation has started to follow and will continue to follow in the years to come. And I am so proud to be able to contribute to this, and I hope that you are too, because it is because of your support that we were able to achieve these great things and will continue to do so. Thank you so much. I'd like to bring Sally Pipes on the stage.
I'm a little bit taller than Naomi, so I have to raise the mic. Naomi worked at PRI back in 94, 95, so we've been friends for a long time and in this battle about healthcare reform for probably too long a time, but we fight till death do us part. At PRI, we're delighted to be co-hosting this event with the Goldwater Institute. So many people from California are moving to Arizona, including our board members, Russ and Colleen Johnson, who are now here. California, I don't know when it's going to get to the abyss and finally things will turn around, but it doesn't look like they're anytime soon with the way the government is structured and the way things are going in San Francisco and Los Angeles. But anyway, Naomi's points are all great and they're all part of my reforms too, so I won't need to go into them. I'm going to talk about the false promise of single-payer health care and its stepping stone approach, the public option. President Biden, as you know, celebrated his 100th day in office on April 30th. Many Democrats in Congress are now becoming increasingly upset with him that his agenda is not being implemented fast enough. On the healthcare front, his issues were introducing a public option, a government-run insurance plan to compete against private insurers, reducing the age of eligibility from Medicare from age 65 down to 60, and of course, giving the federal government the power to negotiate drug prices with the drug companies. As you know, the Democrats took control of the Senate in a way when they lost those 2 Georgia seats, which, was, I think, a shame. And so the split is 50-50, but the sad thing is that former Californian, also Vice President Kamala Harris, has the ability to break a tie vote. She is an extreme progressive, don't make any doubt, there's no doubt about it. She endorsed Senator Sanders, both of his single-payer bills in 2017 and 2019. This razor-thin majority in the House and the Senate, though, I think it's going to make it very, very difficult for Congress to pass either single-payer health care or the public option. So in some ways, that's a good thing. But, it's still, these 2 issues are still very much out there. And there is some thought, 50-50, that 2 Democratic senators, Joe Manchin from West Virginia and your Kristen Sinema here in Arizona, might vote against some of these very progressive ideas. I'm also going to talk a bit about the federal single-payer bill that was introduced in the House by Pramila Jayapal, the House member from Washington State, and Debbie Dingell, the widow of John Dingell from Michigan. They are extreme progressives, even probably more so than Bernie Sanders. I want to talk a bit about what is in Joe Biden's agenda. Unlike Sanders' single-payer goal, he and others are pushing for this public option, which I just mentioned. It is, make no bones about it, it is a stepping stone approach to single-payer. What part of the Biden agenda, of course, is he wanted more generous subsidies for people on the Obamacare exchanges. The $1.9 trillion American Rescue Plan includes the fact that no one would pay more than 8.5% of their income on premium. Under the ACA, that was 10%. The cost of this is just being worked out at $45 billion. And you add that the addition to the deficit would be around $34 billion. And they're only going to add, according to the Congressional Budget Office, 1.3 million uninsured people over 2 years. And most of these people, the 1.3 million, are people who are already eligible for subsidies under the Affordable Care Act. Now, of course, President Biden wants to make this, in the American Rescue Plan, the extension to the 8.5% was from April 1st this year till December 31st, 2022. But President Biden wants this to be part of the American Families Plan, which would make the subsidies permanent. And of course, what government program ever that starts off as a temporary ends up not being permanent. As that great saying, nothing endures like the temporary. And that was the idea of the income tax back in the beginning. So tax credits are now based on the cost of lower deductible, higher premium gold plans that used to be on the silver plan, but now it's up to the gold plan. And this is going to be incredibly expensive. Under the Affordable Care Act, prior to it, in 2014, before it became law, the average family paid about $253, individual, $253 a month for their insurance plan. Under the Obamacare, it's now, this year, $440 a month. So a lot of people did not sign up for exchange coverage because of the cost of the premium and the very high deductibles. Mr. Biden, of course, has signed an executive order setting up a special enrollment period for Obamacare. It was originally from February 1st until May 15th, but he has now extended that till August 15th so that people could sign up for care, particularly if they lost their job during the pandemic. But this is really just window dressing because under the Affordable Care Act, anyone who could prove they had a family catastrophe, lost their job, domestic violence, you were able to sign up for Obamacare outside the enrollment period. So this just was something to make Mr. Biden look good. And also, under the American Rescue Plan, COBRA, which is the plan that you can sign up for if you lose your employer-sponsored insurance, which runs about $7,400 a year. Under the American Rescue Plan, anyone can sign up for COBRA, and it'll be fully funded by the feds until September 1st of this year. Obamacare's regulations included, of course, 10 essential health benefits that were mandated. And many of these, I think that most of these were the reason why healthcare became so expensive, the premium so high, and the deductible so high. Many people, that are earning, $50,000, $60,000 a year cannot afford a deductible, afford to pay $440 a month plus a deductible of over $5,000. So, the essential benefits are, have really added to the cost. There are 12 states under the American Rescue Plan. Under Medicaid, the program for low-income Americans, 12 states did not sign up for the Medicaid expansion. But of course, President Biden said under the American Rescue Plan, any state, the 12 states that haven't, they can expand their Medicaid program, and the federal government will pay 100% of the premium. So of the cost of that. So that's another expensive issue. They also, the Biden administration, sent letters to those states, the states that had allowed for Medicaid work requirements. 70 million Americans today are now on Medicaid. 1/3 of Californians are on Medi-Cal, the state version of Medicaid. So the 7 states that allowed Medicaid work, the federal government has now revoked all of those plans. So there is no Medicaid work going on at the moment. And it's really a great way. A lot of people who are on Medicaid could actually work and contribute to the economy. So there's just so many things that are on the agenda, this progressive agenda. They're also trying to reduce drug prices by introducing price controls, tying prices to the average price of a drug in a MFN, most favored nation, country like Canada, England, Japan, Australia, France. This is going to be a disaster, I think, for innovation, research, and development in this country because, as you know, most of the developments, new innovative drugs, as Naomi was saying, the vaccines, they're developed here in America. They're not developed in countries like Canada and England where they have price controls. The administration and several states are trying to have passed, the governors have signed bills allowing for importation of drugs from Canada, where I'm from. And, even the government officials, liberal officials in Canada say, Canada with 37 million people cannot be the drugstore for America. They don't have enough drugs themselves. And a lot of the drugs that are developed here, which are expensive, and the drug companies offer them to Canadians at a lower price, the Patented Medicines Prices Review Board decides they're still too expensive, so they're not even available. So this is another disastrous idea. And then, of course, the President Biden backed the intellectual property waiver for the vaccine, and that's another disastrous idea. It's another sort of price control. We need to keep the market open for innovation. And even countries that have universal coverage systems and are socialist, like England under the National Health Service, and countries in the European Union have said that the intellectual property waiver is not a good idea. President Biden, as you know, during his campaign would often be up there fighting against Bernie Sanders, saying, I don't support single-payer health care. I support building on Obamacare, which he now calls Biden-care. So, he really, I think, really deep down supports single-payer. But one of his key issues was, of course, reducing the age of Medicare eligibility from 65 down to 60. As we know, Medicare Part A, the hospital part, is forecast by the Congressional Budget Office to be bankrupt by 2024. So here we are. We have 60 million people in this country on Medicare, and now they're talking about adding an additional 23 million at a cost of an additional $100 billion a year over the $800 billion that is being spent on Medicare right now. If you look at Social Security, which is forecast to go bankrupt as well, they're raising the age of eligibility. Why is it that someone like Biden and AOC and Sanders want to reduce the age when it's going to be very, very costly, and it's going to result in ration care, waiting lists, and various other things such as higher taxes, doctor shortages. So just spend a few minutes talking about the public option and what it means. As I say, with the makeup of the House and Senate, I doubt it will, pass Congress. There are two senators, Bennett from Colorado and Kane from Virginia, who have introduced for the third time a public option bill. So they're pushing that in the Senate, and a couple of other senators say they're going to introduce a public option bill. At the state level, there's a couple of states. Washington State signed a public option law. It's turned out to be very expensive and it's not working well. Colorado, they just nixed the public option, even under a Democratic Governor Gerald Polis. In Connecticut, Ned Lamont just said he threatened he would not sign the public option bill that had passed the Connecticut General Assembly. So that's being shelved again. Nevada has passed it in their assembly, and they'll be voting in the Senate. But if you look, these public options, which is a government-provided insurance plan to compete against private insurers, ultimately, the public option government insurance plan will be priced lower than what private insurers can offer their coverage. Private insurers will be crowded out, and ultimately, we will be left in a system of Medicare for all. Because the private insurers would not be able to stay afloat. Bernie Sanders, of course, my nemesis, he's even, called me out on NPR radio shows. I can't believe I've never met the man, but I'm calling him out. So anyway, he is, since the beginning of time, he's been a big advocate of single payer. It became an issue when he was running against Hillary Clinton for the nomination back in 2016, and then he introduced his bills in 2017 and 2019. But it's single payer is the complete government takeover of the healthcare system for anything that is considered medically necessary. That's the way it is in Canada, where I'm from. The government doesn't allow any private coverage for anything considered medically necessary. And of course, 300,000 Canadians cross the border every year and come to the US and pay out of pocket for things that they feel that the waiting time is too long. So, Canadians, they have an escape valve. What will our escape valve be? I guess we'll come to Arizona because you're actually doing some really interesting things. They're certainly not happening in California, where we're going exactly the opposite way. So Senator Sanders announced on March 27th that I think he realizes that the Medicare for All is not going to pass the Senate. So therefore, he went ahead with supporting reducing the age of Medicare eligibility from 65 to 60, or even down to the age of 55. So that, I think he sees that as a real stepping stone for him. As I mentioned, Pramila Jayapal and Debbie Dingell have introduced their Medicare for All Act of 2021. This would be a 2-year transition to single payer. The Sanders bill was a 4-year transition. This would be a 2-year transition. Everything medically necessary would be free at the point of service, and they plan to include free dental care, free vision, free hearing, free drugs, free long-term care. Even Canada doesn't provide any of those things as part of our Medicare program. They keep trying to bring in drugs as part of Medicare, but then they cost it out and they figure they can't afford it. So Jayapal and Dingell continue to speak out saying healthcare is a right. And during the COVID-19 pandemic, it's more of a right than ever. And Sanders, of course, agrees with that too. But healthcare is not a right. It's not a right for the many or a privilege for the few. Healthcare is like any other good and service. And like all goods and services, healthcare is necessarily scarce. Declaring a right to healthcare that is greenlighting unlimited demand for healthcare, and the supply just won't be there to meet that demand. In the UK, the people on the NHS, the government, like 90% of Brits are under the National Health Service, which came into being in 1948. In Britain, if you are, for certain treatments, if you're obese or you're a smoker, you're not even eligible to get the treatment. So would government have the right to tell us how much health care we can get? What kind of health care? Would everyone get the best health care? Obviously not. So from my point of view, it was very depressing that President Trump and that Congress was not able to pass a repeal and replacement of Obamacare. I mean, it was really, we had such a great opportunity. And Trump signed some excellent executive orders, short-term limited duration plans, association health plans, expanding health reimbursement accounts, health savings accounts, and brought in price transparency for hospital costs. These were all very wonderful and very helpful ideas. But unfortunately, as you know, the former California AG, Mr. Javier Becerra, is now Secretary of HHS. He knows very little about healthcare, but he has been a supporter. For the 24 years he was in the House for Medicare for All, he supported various bills. He is still a huge supporter of Medicare for All. He just said the other day that he's going to get rid of short-term limited duration plans, which cost about $100 a month. They're not for everybody, as Alex Azar used to say, but they do provide health care, particularly for younger people, at a cost, as I say, of about $100 a month. It's a lot cheaper, and it covers a catastrophic situation. So Becerra also, brought 100 lawsuits against Texas and other states' attorneys general because he believes the individual mandate does not make the rest of the law of the Obamacare unconstitutional. So he is a big supporter of more government in our health care, and we're going to see that. California, Ash Kalra and Miguel Santiago, they reintroduced the single-payer bill in California. It has been shelved, and I think it has to do with the fact that Governor Newsom is under a recall, and he probably didn't want to have to, deal with, the single payer, and it'd be the nurses versus the SEIU, pushing this, and I think he felt that it might harm his position to be recalled. So that's on the shelf. They say they'll bring it back next year. We'll see. They keep trying in California. I've been fighting against single payer in healthcare since 1992, and we've managed to keep our finger in the dike, but it's getting tougher and tougher as I get older and older. So, and New York State, for the first time, they have a Democratic-controlled legislature there, and they have, for 30 years, they've been trying to get single payer in the state of New York, and Richard Gottfried, the assembly member in New York, says, finally, I think we can get it done, but the cost would be $250 billion a year, and I don't even think Como would be excited about the cost of all of that. So there's a lot going on. I spend my time fighting for healthcare freedom. We want to, empower doctors and patients. As Naomi pointed out, competition and choice are the key to affordable, accessible, quality care for all. As Charles Bleyhouse from Mercatus and the Urban Institute have said, the cost of a single-payer bill in this country, $30 to $40 trillion over 10 years. If you doubled all the corporate and personal income taxes, it wouldn't be enough to cover it. Doctors would be paid 40% of what they're paid today because the government is in control, and they need to cut the costs. There'd be a doctor shortage. We already know the American Association of Medical Colleges says by 2030 there will be a shortage of 139,000 docs. Many are leaving medicine because of the rules and regulations and mandates on them. It's also been pointed out that if they've got Medicare for All, 44,000 more doctors would quit medicine. In Canada, where I'm from, the average wait from seeing a primary care doctor to getting treatment by a specialist, over 5 months, 22.6 weeks. Back in 1993, when we started at the Fraser Institute our study, Waiting Your Turn, a guide to waiting lists, it was 9.3 weeks. So this is a complete disaster. The older you are, the less likely you're able to get care, and you don't have access to the greatest care. Michael Bublé, one of my favorite crooners, who has a great Christmas CD, when he lives in Vancouver, when his 3-year-old son Noah was diagnosed with liver cancer, they didn't stick around at Vancouver and go to the Cancer Control Agency and what kind of treatments. They immediately went to Los Angeles to the Children's Hospital of LA. And now his son is 6. Cancer is completely in remission. And he said, we got the best care and we had the very best of doctors. So, people like Michael Bublé have a choice. But most Canadians, like my mother, who died from colon cancer as a senior because she couldn't get a colonoscopy because there were too many people below the age of 65 who were on the waiting list and needed a colonoscopy, and you want to keep the younger people alive rather than the older people. So, these are things that people need to realize that what happens under a single-payer system. Ration care, long waiting times, higher taxes, doctor shortage, and not the very best in people in medicine. And I worry too that in this country, if we got single payer, usually the best and brightest kids go into medicine. It's very competitive. The best and brightest don't want to go in and become a public servant like people at the DMV or at the U.S. Post Office. So very, very, very sad. But in the polling, 58% of Americans polled under Gallup and Kaiser Health News support single payer. 68% are supporting the public option. 49% of doctors support single payer. I think a lot has to do with, as Jeffrey knows, with all the rules and the mandates and the electronic health records. But it's when you poll people, so 58% support it, 68% the public option. But when you then ask them, well, you 160 million Americans who have employer-sponsored coverage, 71% rated as good, would you still support it? And support goes down to 13%. So we have a huge educational job ahead of us to educate people, not the people in this room, but people in the general public about the impact and the false promises of single payer. Under COVID in Great Britain, there are now 4.5 million people on the NHS waiting list, and they think it could go up to 10 million because there's such a lack of capacity in the hospitals that people, delayed getting treatments, they couldn't get their surgeries, they couldn't get their cancer treatments, all of these things. When government is in control, they determine who gets what and when. The British Medical Association has said that cancer survival rates 5 years out are probably going to decline precipitously because of people not being able to get access to tests for cancer and other important diseases. The former Nigel Lawson, former Chancellor of the Exchequer in Margaret Thatcher's administration. You have a wonderful picture of Margaret Thatcher. I love her hairdo out at the Goldwater Institute. It's really fantastic. But he said, the National Health Service is the nearest thing to a religion and cannot be criticized. The Guardian said, the National Health Service is the world's best healthcare system. The only black mark on it is its poor record of keeping people alive. And Chris Jagger, who is now 73, the younger brother of Mick Jagger, the Rolling Stones frontman who is now 77, is still gyrating around the stage. Wow. He said in August of 2019, when Mick went, as a British citizen, went to New York Presbyterian to have his heart replacement surgery done. Thank goodness that Mick didn't have to stand around in line waiting for the National Health Service. So we're all grateful that Mick Jagger is still up there on the stage. So there's so many things that we need to fight for getting free market ideas into the healthcare system. Certainly, as Naomi pointed out, under COVID, the emergency use authorization for the Pfizer drug and the Moderna drug, and then more recently the J&J jab. It's amazing what they can do when they put their mind to it. And let's hope that these things, get permanent acceptance, and that we have continue to have a market where these things can continue to be, where America can continue to be the best place for innovation. Because as I say, where would we go if we go to single payer or a public option stepping stone approach? My friend P.J. O'Rourke, Naomi worked at the Cato Institute also back in the day before she came to PRI. He said, if you think healthcare is expensive now, just wait until it's free. Choice and competition are the way to affordable, accessible, quality care. And all the things Naomi talked about, telehealth, scope of licensure, reducing medical school GP terms from say 4 years down to 3. Duke is trying it, University of Ohio. There's a number of things that can be done that can open up the market. We need retail clinic expansion. We need more price transparency needs to become law. We need to expand HSAs, health reimbursement accounts. We need to reform Medicare and Medicaid, not reducing the age of eligibility for Medicare, but actually increasing it. So people like Warren Buffett doesn't really need to be on Medicare. He can afford the very best that should be there for those seniors who really need a government program. So, as I say, choice and competition are what we want, and every other aspect of our life we have. So we have to stop this trend to single payer or the public option. It will be a disaster for all of us. Thank you very much.
If you like this episode, please tell your friends and subscribe to PRI's podcast at iTunes, Google Play, Stitcher, TuneIn, iHeartRadio, and Spotify. And when you're on these platforms, don't forget to give us a big 5 stars. If you don't subscribe to any of these, you can still listen on PRI's YouTube page, youtube.com/Pacific Research 1. That's the number 1. Thanks for listening. I'm Rowena Ichon. Hope you'll come back again for next round with PRI.